Welcome to the Deep Dive. Today we're tackling something really foundational for any nursing student heading into pediatrics, the assessment itself. We've dug into some excellent notes, mainly drawing from Wong's Nursing Care of Infants and Children, and, well, our goal today is to pull out the real core knowledge you need.
Yeah, the essentials.
Exactly. How to do assessments that are thorough, but also, really fit the child's specific developmental stage.
Yeah.
We want you to leave feeling more confident about approaching kids.
Absolutely. Because a good pediatric assessment, it's more than just checking boxes. It's really the foundation for effective care.
Right.
It's how we truly get a picture of that child's health, spot potential issues early, and importantly, tailor our care based on where they are developmentally.
Okay, so let's start unpacking that. The source material really kicks off with communication.
Yeah.
It seems like it's way more than just asking, so what brings you in today?
Oh, definitely. It's fundamentally about building that connection, what we call the therapeutic relationship. You need that trust, that understanding, and not just with the child, but critically with the caregivers, too. They're the experts on their child, after all.
So how do we actually do that, build that trust, especially when kids might be, anxious or scared in a clinic or hospital?
Well, the notes really highlight using open-ended questions. Get them talking, sharing their view, and active listening, really hearing them, acknowledging what they say that builds rapport fast. Empathy, too, showing you understand how they might be feeling.
Makes sense.
But the techniques, they have to change drastically depending on the child's age. This is where it gets kind of fascinating.
Okay, tell me more. Like, how does it differ across age groups?
Well, for infants, 0 to 12 months, it's all about nonverbal cues.
Right, the crying, the smiles.
Exactly. You got to tune into that. Use a soft, soothing voice, gentle touch, that's your language.
Okay.
Then, toddlers, 1 to 3 years old. Simple words, keep it concrete. Bring in play, use toys. That can really change the dynamic.
Because they're so focused on themselves at that age.
Totally. It's an egocentric world. Explaining something like, this will help your tummy feel better so you can play, works way better than complex medical talk.
That clicks. They wouldn't get the abstract stuff.
Nope. Preschoolers, you can use their imagination more. Storytelling, maybe drawings to explain things visually. Keep explanations short, though.
Still short and sweet.
Yeah. School-age kids, they get more. So be honest. Explain procedures clearly. Let them ask questions. Encourage it.
Right.
And then adolescents, big shift. Privacy is huge. Listen without judgment. Respect their autonomy, their independence.
So it really is a moving target depending on who's in front of you. What about when words aren't the main thing, nonverbal?
Hugely important, especially with kids. They pick up everything. Your facial expression, how you stand, your gestures. You can either build trust or, accidentally scare them without saying a word. It's something you have to be conscious of.
And the parents or caregivers, they're obviously key in this communication loop too.
Oh, absolutely critical. You need to acknowledge their expertise, keep things confidential, and really involve them as partners in decisions about care. They know their child best.
The notes also brought up telephone triage. That sounds like a whole different ballgame for communication.
It really is. You're relying heavily on protocols, structured questions to get the info you need remotely.
Right. No visual cues.
Exactly. The goal is to figure out how urgent things are, get clear on the symptoms, what the caregiver's already tried, give safe advice, and then crucially document everything meticulously.
Okay, so communication is like step one, the foundation. Once we've started that conversation, where do we go next?
Then you move into gathering the story, the comprehensive health history. This is where you start piecing together the narrative of the child's health.
The health story. I like that. What are the key parts, the chapters?
You start with the basics, identifying info name, age, gender, who the caregiver is, then the chief complaint, the CC.
Why they're here today.
Exactly, and ideally in their own words. Then comes the HPI, history of present illness. This is the deep dive into the current problem.
Okay.
You explore onset, location, duration, severity, what makes it better or worse, any related symptoms, really painting a detailed picture.
Getting the specifics of the now.
Precisely. After that, you look back, the past medical history, or PMH.
Okay, what does that cover?
Everything from birth history, gestation, weight, any issues, to past illnesses, surgeries, definitely immunizations, and super important, allergies or any bad reactions.
Got it.
Family history is also key. You're looking for genetic links, chronic conditions that might run in the family.
Makes sense.
Yeah.
Anything else for this history part?
Yep. Psychosocial history gives context, living situations, school or daycare, social stuff, support systems.
The bigger picture.
Right. And nutritional history is vital breast or formula, solid foods, supplements. And finally, the review of systems, the ROS.
That head-to-toe checklist.
Sort of, yeah. It's a systematic run-through of body systems, asking questions to catch anything maybe the caregiver didn't think to mention initially.
Wow, okay, that sounds incredibly thorough. Like building a detailed timeline. Then the notes pull out nutritional assessment as its own big focus. Why the special attention there?
Well, because nutrition is just so tightly linked to everything for a child, growth, development, overall health, a good nutritional assessment helps us catch things early.
Like what kinds of things?
Growth problems, maybe malnutrition, or even heading towards obesity.
And how do we assess that? What are the tools?
Usually involves getting dietary info, maybe a 24-hour recall, or asking about food frequency.
Okay.
For babies, you look closely at feeding behaviors latch, how often they feed, any struggles, and the cornerstone is tracking growth chart data.
Weight, height, BMI.
Exactly. Meticulously tracking weight, height, or length, and BMI over time. You're looking for patterns, any drift away from their expected curve.
You mentioned patterns. Are there subtle things on those charts we should watch for beyond just one single point?
That's a really good point. What should we be looking for in those trends?
Yeah.
So instead of just saying, oh, they're on the 10th percentile, look at the trend. Are they suddenly dropping percentiles? Or consistently gaining very slowly across multiple visits? That can be more worrying than a child who's always tracked along, say, the 5th percentile steadily.
So the crossing of lines or a flattening curve is a flag.
Right. And also consider family context. Are the parents naturally smaller or larger? That context matters for interpretation.
That trajectory idea is really helpful. Adds nuance.
Okay, next up in the notes is developmental assessment. How does this fit in?
This shifts the focus a bit from just physical health and nutrition to checking if the child is hitting those age-appropriate milestones.
Like walking, talking.
Exactly.
Yeah.
Across different areas. It's super important for catching potential developmental delays early when intervention can make the biggest difference.
What tools do we use for that?
We often use standardized screening tools. You might have heard of the Denver Developmental Screening Test or Ages and Stages questionnaires, the ASQ. These give us a structured way to look at gross motor skills, fine motor, language, social skills, even cognitive abilities like problem solving.
So it's a really holistic look at their progress. Okay, now we get to the part many people think of first.
Yeah.
The hands-on physical assessment.
Exactly. This is where we actually examine the child. But, and this is key, it has to be flexible.
Flexible how?
You have to adapt based on the child's age, their temperament, are they shy, outgoing, and their health state right then. You can't just force a rigid head-to-toe exam on a scared 2-year-old. It just won't work well.
The notes mention things like letting the child stay on the caregiver's lap, using distraction. Those sound like practical ways to get cooperation.
They're essential strategies. Making them feel secure is number one. Explaining things simply, showing them the equipment maybe.
Like letting them hold the stethoscope.
Yeah, for a preschooler, that can work wonders. And distraction is your friend, a toy, a song, just talking to them about something else that can really help keep them calm.
And the order we do things in seems to change with age, too. Why is that? The main idea is do the least invasive, least scary stuff first for that age group.
Okay.
So for infants, you might listen to their heart and lungs first while they're quiet, maybe even asleep.
Because that requires quiet.
Right. Toddlers. They often resist things they see as intrusive, so you might start with just looking, listening to their heart, and save the ears and throat exam for the very end.
Save the potentially upsetting part for last. That makes total sense. What about older kids?
Preschoolers, like you said, letting them handle some equipment can help. School-age kids usually do okay with a head-to-toe approach as long as you explain each step clearly and honestly answer their questions.
And adolescents.
Privacy, privacy, privacy. And respect their space. That's crucial for building trust and getting an accurate assessment with teenagers.
Okay, got it. So what are the key things we're actually looking at during the physical exam?
Well, you start with growth measurements. Weight, length, head circumference for babies, height, weight, BMI for kids 2 and up. Then vital signs. And remember the best order. Respirations first, then pulse, then temperature.
Respirations, pulse, temp. Why that specific order?
Good question. Why is that sequence important?
Yeah.
Well, respirations are easiest to get accurately when the child is calmest before you potentially disturb them.
Yeah.
Taking a pulse or temp might make them fuss or cry, which definitely changes their breathing rate. Pulse is usually next least invasive. Temperature, depending on how you do it, can be the most upsetting. So doing it last prevents it from messing up the other readings.
That's a really practical tip. Okay, what else do we assess?
You look closely at their general appearance, hygiene, posture, alertness, their overall mood or effect.
Right.
Examine the skin color, any rashes, lesions, check hydration. A thorough heat exam, head, eyes, ears, nose, throat. Looking at fontanelles in infants, checking eye alignment, vision screening, ear position, hearing screening. Listen to the chest and lung symmetry, breath sounds. Auscultate the heart, apical pulse. Listen for murmurs, check capillary refill.
Wow, covering all the bases.
We try. Then the abdomen inspect first, listen for bowel sounds, then palpate. Genitalia, if needed, always ensuring privacy and explaining why. Musculoskeletal system, watch their gait, check joint movement, screen for scoliosis in older kids. And finally, a basic neuroassessment, reflexes, coordination, how they respond to things.
Okay, that covers the hands-on exam. But the notes also talk about developmental surveillance and screening. How are those different from the developmental assessment we discussed earlier?
That's a good distinction to make. Developmental surveillance is more like an ongoing informal check.
Like at every well-child visit.
Exactly. You're continuously observing their motor skills, speech, social interaction as part of regular care. Screening is more formalized.
Using specific tools.
Right, using those validated tools like the ASQ, PEDS, or the MCHAT for autism risk, usually at specific recommended ages, to get a more structured snapshot of their development.
Okay, so surveillance is ongoing observation. Screening is using specific tools at set times.
Yeah.
Got it. Now, what about special situations? Times when the standard approach needs tweaking.
Absolutely. Cultural competence is huge. You have to be aware of and respect different cultural norms around communication, touch, family roles, and healthcare.
That makes sense.
And for kids with chronic illnesses or developmental disabilities, you definitely need to adapt. Adjust your expectations, tailor how you assess based on their specific abilities and communication style.
And the notes also mention the really tough topic of suspected maltreatment.
Yes. And in those incredibly difficult situations, objective documentation is everything.
It's just the facts.
Precisely. Record exactly what you see and hear, no assumptions, no interpretations. And critically, every healthcare professional needs to know and follow their mandated reporting laws and facility policies to the letter.
A really challenging but vital responsibility. Okay, lastly, doing the assessment is one thing, but recording it properly is just as crucial, isn't it? Let's talk documentation.
Unequivocally, it's absolutely essential. Accurate, objective, timely documentation of everything, findings, measurements, parent-child concerns, what you did, any referrals.
Why is it so critical?
Well, for continuity of care between providers, for legal reasons, and just for tracking that child's health over time, the record is vital.
Right. So, wrapping this up, it sounds like a comprehensive pediatric assessment is this really dynamic, layered process. Starts with communication and trust, goes through detailed history gathering, looking at nutrition, development, the physical exam adapted for age.
Ongoing surveillance and screening.
Always considering special factors like culture or chronic conditions, and then finishing with solid documentation.
That sums it up well. It's about seeing the whole child, understanding them in their family context, at their developmental stage, and considering their unique situation.
So for all you nursing students listening, here's something to think about. Considering all these unique communication styles and developmental stages we've talked about, how will you consciously weave these assessment principles into your own practice to provide care that's truly impactful? Definitely something to reflect on. Thanks for taking this deep dive with us today.